The late afternoon sun cast long, warm stripes of light across the floor of the patient's room. In the quiet hum of the hospital, a nurse sat vigilantly by the bedside. On the monitor above, a steady green line traced the rhythm of a heartbeat, a stable heart rate, blood pressure well within normal limits, an oxygen saturation of 98%. It was a picture of electronic calm. Yet medicine is rarely so simple. It is a discipline of the senses, as much as it is of sensors. The nurse, practiced in this art, leaned forward slightly, her attention drawn not to the screen but to the patient. Her eyes narrowed, catching a detail the monitors could not. The patient's breaths were shallow. They were quick, almost imperceptibly so. There was a subtle asymmetry to the movement. Left side, a confident, full excursion. Right side, hesitant, lagging, less expansion. This was the mismatch moment, clinical reality diverging from the data on the screen. She did not press an alarm, she observed. She placed a hand on the patient's shoulder and watched the chest, counting respirations herself. 22 breaths per minute. The monitor, averaging over time, still read 18. She watched the neck muscles, noting a faint flicker of the sternocleidomastoid, a sign of accessory muscle use, the body recruiting reinforcements. This is where nursing and medicine find their craft, between the numbers and the patient. Before a crisis announces itself with loud alarms and plummeting numbers, the body often whispers its warnings. For a developing pneumothorax, where air escapes the lung to occupy the pleural space, causing the lung to collapse, these whispers are spoken in the language of respiration. The first changes are almost always subtle, a slight deviation from the patient's baseline. The respiratory rate, that most basic of vital signs, may creep up from 16 to 20, then to 22. It is a change so gradual it can be easily missed or attributed to anxiety or minor discomfort. But it is a signal, a sign that the body is trying to compensate for a new inefficiency in its oxygen exchange system. The depth of each breath, or tidal volume, begins to diminish. As air fills the pleural space, it exerts pressure on the lung, restricting its ability to fully inflate. The patient, often unconsciously, begins taking shallower breaths to avoid the sharp pleuritic pain that can accompany a deeper inhalation against this new resistance. This leads to the third sign, a change in effort. The work of breathing, normally an automatic and effortless process, becomes a conscious task. Flaring of the nostrils, use of neck muscles, sitting upright, leaning forward. It is the body's silent, desperate attempt to make breathing easier. Symmetry is another crucial vocabulary word in this silent language. A healthy chest rises and falls in a balanced, synchronous motion. With a pneumothorax, this symmetry is broken. The affected side, its lung now partially compressed, will move less. This can be difficult to spot, especially in a small pneumothorax, but it is often the most specific, early physical sign. Placing your hands on both sides of the patient's chest can make this tactilely obvious. You can feel the imbalance in the excursion. Auscultation with a stethoscope adds another layer. Breath sounds become diminished, distant, absent altogether. The air in the pleural space acts as an insulator, muffling the sound of air moving within the lung tissue below. When a pneumothorax is suspected, the chest X-ray becomes our primary tool for confirmation. It is a simple, two-dimensional map of a complex, three-dimensional space, and reading it correctly is a skill built on a few foundational principles. The first and most important is understanding how different substances appear on the film. Think of it in simple terms. Air is black, dense things are white. Because X-rays pass easily through air, the air-filled lungs appear dark. Conversely, denser materials like bone, heart muscle, fluid absorb more X-rays and therefore appear white or light gray. A pneumothorax is, by definition, a collection of air where it shouldn't be, outside the lung. Therefore, we are hunting for an area of abnormal, pure blackness. This hunt is guided by the skyline principle. The edge of the lung creates a line against the air or structures next to it. In a pneumothorax, the lung pulls away from the chest wall, and a new skyline appears, the visceral pleural line. This is the thin, white, penciled edge of the collapsed lung, separated from the chest wall by a space of pure black, the pneumothorax, which will be devoid of the lung's normal vascular markings. This line can be maddeningly subtle, especially when the collapse is small. Often, the first place to look is at the apex, the very top of the lung, as free air will rise to the highest point in an upright patient. To avoid being fooled by artifacts or subtle anatomy, a systematic approach is essential. We use a simple three-step checklist: quality, compare, correlate. First, assess the quality of the film. Is the patient properly centered, or are they rotated? Rotation can create misleading shadows that mimic or hide a pneumothorax. Is the exposure correct? An underexposed too white film can obscure the faint pleural line. An overexposed too dark film can make normal lung tissue look like free air. Without a quality film, your diagnosis is built on a shaky foundation. An imperfect film doesn't mean you can't make a diagnosis, but you must be aware of its limitations. Second, compare. Whenever possible, find a previous chest X-ray from the patient's record. Comparison is one of the most powerful tools in radiology. The final step, correlate, is where clinical acumen and diagnostic imaging merge. You must correlate the findings on the film with the patient at the bedside. Dark space on the right of the X-ray, diminished breath sounds on the right, reduced chest wall motion on the right. Does the pneumothorax location explain the patient's sharp, localized pain? This synthesis is critical. An X-ray finding in a vacuum is just a shadow. An X-ray that explains the patient's signs becomes a diagnosis. The moment the puzzle pieces click into place. The nurse retrieved the newly developed chest X-ray film, still warm from the printer, and clipped it onto the view box. The fluorescent light hummed, illuminating the grayscale chest. Her eyes scanned systematically. Quality. Film slightly rotated but adequate. Compare. She pulled up the admission film from 2 days prior. Lungs were clear then. Now her eyes went to the apex of the right lung. A fine, delicate white line. Just beyond it, a sliver of vascular-free black. Small, about 1 centimeter collapse, but unmistakable.
She picked up the phone and paged the physician. "I have a patient in room 412, she said, calm and sure.
Respiratory rate up to 22. Diminished breath sounds on the right. Chest X-ray shows a small right apical pneumothorax. She didn't wait for the official radiology read. The radiologist would eventually see the same line in a dark reading room. But the nurse had already connected the dots at the bedside. Her actions were a time-saving bridge, not a replacement for radiology. Good patient care is a system of checks and balances. Trust the monitor data, but trust your senses more. Decode shadows on an X-ray, but listen to the quiet language of breathing. In the warm, soft light, the nurse watched the team prepare to intervene. Her small, early observation changed the course of the afternoon, turning a potential crisis into a controlled, manageable event.